All right, so our today's topic is organ-specific and mid-spectrum autoimmune disease, part 2. As yesterday we discussed part 1, organ-specific and mid-spectrum autoimmune diseases. Today's topic, we are going to start with autoimmune liver diseases. So autoimmune liver diseases, it is characterized by hypergammaglobulinemia, prominent lymphocytes and plasma cell inflammation of the liver, and also the presence of one or more circulating tissue antibodies, which is typically manifested in autoimmune hepatitis. So autoimmune hepatitis is also known as chronic active hepatitis. It is an inflammatory condition, most common in young women, and antinuclear antibodies using human epithelial cell will have different levels of reactivity depending on factors such as the disease activity or multiple antinuclear antibody specificities. So in fact, the staining or immunofluorescence staining, it will be a pattern, it will be a homogeneous staining pattern in the most active form of acute hepatitis. So what you call a homogeneous staining, it is that the entire nucleus is stained, it is showing diffuse staining, and this is actually a solid staining of the nucleus without apparent masking of the nucleoli, but sometimes apparent masking of the nuclei is also noted, but that is what you call homogeneous staining in immunofluorescence antinuclear antibody staining. The frequency of positive antinuclear antibody test in acute immune hepatitis is 70%, but in remission, the frequency of antinuclear antibody positivity can decrease, and the antinuclear antibody pattern is replaced by speckled pattern in almost 40% of the cases. So in remission period, of course, remission is sometimes the absence or recovery, a bit of recovery or absence of symptoms. That's what we call remission period. You find that antinuclear antibody are still positive, but it will only be speckled but not homogeneous, and it is almost in only 40% of the cases is going to be speckled pattern staining. Other significant antibodies can include atypical perinuclear antineutrophil cytoplasmic antibody in one type of acute active immune hepatitis, which frequency of 60% positivity of perinuclear antineutrophil cytoplasmic autoantibody. So in addition as well, active immune hepatitis is characterized by autoantibody to cytoskeletal proteins as well in the cells of the liver. So the patients may display antinuclear antibodies and as anti-smooth muscle antibodies, which is ASMS, and a high and persistent titer of anti-smooth muscle antibodies will always suggest the presence of autoimmune form of chronic active hepatitis or viral disease such as infectious mononucleosis. So anti-smooth muscle is a good indicator of chronic active hepatitis or autoimmune form of chronic active hepatitis, or sometimes even autoimmune form of viral disease like infectious mononucleosis. So the second mid-spectrum autoimmune disease, apart from active autoimmune hepatitis, it is idiopathic biliary cirrhosis. So idiopathic biliary cirrhosis is also another autoimmune disease which is characterized by a slowly progressive disease which starts as an apparent non-infectious inflammatory disease of the bile ducts of young to middle-aged women. So patients will exhibit increased serum immunoglobulin M and depletion of cellular immunity with a prominent decrease in suppressor T cells, and this is associated with associated autoimmune disease and anti-mitochondria antibodies directed against structure of the nucleus of the cell, which is mitochondria, can also be displayed. So in idiopathic biliary cirrhosis, you find anti-mitochondrial antibodies that are directed against mitochondria of the cell. But also we find as well serum IgM increase and also depletion of cellular immunity in this idiopathic biliary cirrhosis. So a high titer of anti-mitochondrial antibody is a suggestion of primary biliary cirrhosis. So, but absence of mitochondrial antibody is also evidence of evidence against primary biliary cirrhosis. So, which means that a prominent autoantibody that is found in this condition, primary biliary cirrhosis, is anti-mitochondrial antibody. And remember, anti-smooth muscle antibody is found in hepatitis or in autoimmune hepatitis, anti-smooth muscle. So anti-mitochondrial is a suggestive of biliary cirrhosis or idiopathic biliary cirrhosis. The third autoimmune disease that we know, of course, it is inflammatory bowel disease, which is also called Crohn's disease or ulcerative colitis. Both of them are inflammatory bowel diseases. So the hallmark of the disease is abnormal immune system or abnormal immune response to harmless bacteria in the gut. And inflammatory bowel disease patients, this microorganism become target for immune system of these patients. Whereas, of course, these microorganisms are very harmless in the gut, and they can actually be, we can also benefit from them, and they can benefit from host. So the studies have suggested that one is cytokines, which is interleukin 12, is a crucial mediator of this disease, and interleukin 12 can cause inflammation by activating CD4 cells, which in turn produce pro-inflammatory molecules, for example, interferon gamma, as well as tumor necrosis factor alpha. So these two pro-inflammatory mediators, like interferon gamma and tumor necrosis factor alpha, they are mediator of these inflammatory bowel disease, which is ulcerative colitis and Crohn's disease. So this is normally due to the mediation of interleukin 12, which stimulates CD4 cells, and they will also produce or secrete pro-inflammatory molecules. So immune markers that are found in this condition, the following markers are found in especially in Crohn's disease and also ulcerative colitis. The first marker, immunologic marker, is of course antibodies, anti-deoxyribonuclease antibodies, anti-saccharomycin cell-VA antibodies, and also pancreatic antibodies in some patients of Crohn's disease. And then we have also anti-outer membrane purine for Escherichia coli, so which is also another indicator or another finding in this ulcerative colitis and also Crohn's disease of the inflammatory bowel syndromes. So celiac disease is also another autoimmune disease. So it's a lifelong autoimmune intestinal disease which is found in individuals who are genetically susceptible to celiac disease. So damage to the mucosal surface of the small intestine is caused by immunological toxic reaction to the ingestion of gluten. So gluten is found in some foods, for example, wheat, grains, and cassava. Sometimes you find the gluten. So food component gluten has been identified as a trigger of celiac disease. So key diagnostic assay comprise testing for autoantibodies against tissue transglutamase, which is anti-TTG, tissue transglutamase, as well as endomysium A, which is antibody against endomysium, and also antibodies against deamidated gradient peptides and celiac disease associated human leukocyte antigen DQ2 and DQ8. So these are the autoantibodies that are normally found in celiac disease. Of course, that is because of the damage to the intestinal mucosa, small intestine mucosa. So because of the stimulation of some of this gluten, which is a molecule that is found in different grains and wheat and cassava and the other types of foods. The only people who are susceptible to this reaction, that the ones, of course, who normally react to gluten. Not everybody that reacts to gluten. So autoimmune hematologic disease are also very common. They are also very common autoimmune disease. For example, autoimmune lymphoproliferative syndrome. So the autoimmune lymphoproliferative syndrome is a disease in which a genetic defect in apoptosis leads to the breakdown of lymphocyte homeostasis and normal immunologic tolerance. So this is what happened. In fact, there must be a process of apoptosis in every cell, but in autoimmune lymphoproliferative syndrome, there is a problem of breakdown of normal homeostasis of lymphocytes. So which means that normal apoptosis is not taking place. So the defective apoptosis in lymphocytes is going to lead to accumulation of cells in lymphoid organs after they would normally have been eliminated. Of course, as you can see, apoptosis is not triggered because there is a defect in apoptosis process, so which leads to the overaccumulation of lymphocytes in lymphoid organs. So as a result of accumulation of these cells with the autoimmune potential, they will go unchecked and can induce a variety of autoimmune disease. So because of failure to die for those cells because of defect in apoptosis, which is a programmed cell death, so this will lead to accumulation of unchecked autoimmune potential lymphocytes, those cells that are able to induce autoimmunity. So the risk for malignancy transformation is also very high, and the patient with this autoimmune lymphoproliferative syndrome, they will have chronic enlargement of the spleen and lymph nodes, and various manifestations of autoimmunity will also be in place, and also elevation of normally rare population of double negative T lymphocytes. So what is double negative T lymphocytes? Those are the cells that they don't possess either 4 or 8. So not 8 plus or 4 plus, not CD4 plus, not CD8 plus. So they are called double negative T cells. Because T lymphocytes, they must actually be either CD4 plus or CD8 plus. So if there's no CD, either 4 or 8, so we call them double negative cells. Also, these cells are also present in this condition. So most autoimmune lymphoproliferative syndrome patients, they have mutation in the tumor necrosis factor receptor gene, previously which is known as APT1, and which encodes for the surface antigen receptor for major apoptosis pathway in mature lymphocytes. So because a tumor necrosis factor receptor on lymphocyte is the one which receives signals from tumor necrosis factor that stimulate apoptosis. So because the receptor for the tumor necrosis factor is defective, then apoptosis will not take place. So this receptor is very important in elimination of excess T lymphocytes. So when, of course, this is a case, T lymphocyte will not be eliminated, and they will accumulate, and those cells can lead to autoimmunity. So autoimmune hemolytic anemia, of course, you remember that autoimmune hemolytic anemia, we have like different autoimmune hemolytic anemia which affect, of course, blood cells. These are, of course, hematologic or hematological autoimmune disorders. Autoimmune hemolytic anemia can be classified in 4 groups. The first group of autoimmune hemolytic anemia is warm reactive autoantibody, which is most common. The second one is cold reactive autoantibodies, and also paroxysmal cold hemoglobinuria, as well as drug-induced hemolysis. So these are the 4 groups of autoimmune hemolytic anemia. So the first one, which is warm autoimmune hemolytic anemia, So this anemia is associated with antibodies reactive at room temperatures, right? So this autoimmune hemolytic anemia is associated with antibodies reacting at room temperature, and of course those autoantibodies are able to react at 37 degrees, and a group of those autoantibodies are in a group of IgG, because IgG is able to react at room temperature and it is also able to activate complements. So warm autoimmune hemolytic anemia, negligible serum autoantibodies may be continuously absorbed by RBC in vivo, and then elution of those antibodies from RBC can demonstrate autoantibody. So this is how we can screen or we can test for warm autoimmune hemolytic anemia. It is just that we are trying to detect those antibodies that are able to react at 37 degrees and they are able to destroy red blood cells. So those antibodies that are adsorbed by RBC, so which means they are now accepted and they are able to attach on RBC in vivo or in the body, right? And those cells will be destroyed because of complement activation, because complement can be able to work at 37 degrees. So in fact, of course, for us to detect those antibodies on RBC, we are going to perform what is called elution technique, which is to remove or to detach RBC antibodies from RBCs in order to test them in lab. So that is how we deal with elution technique in order to detect those antibodies. So we have also cold reactive. In autoimmune hemolytic anemia, we have what you call cold reactive autoantibodies or cold reactive autoimmune disease. So cold reactive autoimmune disease, it is also what you call cold hemagglutinin disease, which is acute or chronic case and is the most common type of hemolytic anemia associated with the cold reactive autoantibodies. So the acute form is secondary sometimes to mycoplasma pneumonia infection or sometimes lymphoma. So and also Renal phenomena, hemoglobinuria will also occur in this condition in cold weather. So in cold hemagglutinin disease, what we find here is a cold reactive antibodies, and the cold reactive antibodies are in the class of IgM, right? IgM are always cold antibodies, and these cold antibodies we are able to find them in cold reactive autoimmune disease, right? So cold antibodies are able to react with RBC in peripheral blood circulation when the temperature falls to 32 degrees. For example, lower extremities, or even like limbs, of course, legs, feet, palms of the hands, right? That's where we find this temperature 32 degrees is actually at extremities. So in this condition now, those IgM antibodies, they are not able to react at 37 degrees, but they are going to react at 32 degrees because this is a cold temperature of the body. And if they are now able to bind red blood cell in those extremities, they are able to bind the complements and activate the complements. So there's going to be hemolysis of RBC because of complement activation by IgM, but not because of IgM destroying red blood cells. Because now when the blood is continuing to circulate, it is going to reach a point where degree is normal body degree, which is 37 degrees. And at the 37 degrees, IgM is not able to react, but complements are activated and they are able to destroy red blood cells. So the complement is the only protein that you are able to detect on erythrocyte. Now you can be able to notice here the difference between cold reactive autoimmune disease and warm autoimmune disease. Because in warm autoimmune disease, we are able to detect even IgG antibodies. Autoantibodies are detected, but in this condition, in cold autoimmune disease, we cannot detect autoantibodies because autoantibodies that are IgM cannot be corrected in a blood sample, because the blood sample that we are correcting, it is corrected from 37 degrees site of the body. So we can't correct IgM, but we can only be able to detect complements, because complement will still be reacting at 37 degrees. So that's the difference between cold and warm autoimmune disorders. So as you can see, if we correct blood sample at 37 degrees, we cannot be able to demonstrate antibodies at this temperature, right? So we can only be able to demonstrate complement proteins. So the third condition, which is also autoimmune hemolytic anemia, is what you call paroxysmal cold hemoglobinuria. Paroxysmal cold hemoglobinuria has been associated with syphilis and also the presence of hemoglobinuria, of course, hemoglobin in urine, but now is seen to be also secondary to viral infection, especially in young children. So it has also been occurring as idiopathic in other people, idiopathic disease, which is of course a disease without a known cause. So an autoantibodies that is seen in paroxysmal cold hemoglobinuria is IgG protein as well, that is able to react with RBC in the colder part of the body. So this antibody is called biphasic antibody. It is able to react in the colder part of the body, and this can produce also a binding of complement C3 and C4 complement proteins. But at warmer temperatures of the body, RBC are hemolyzed and antibody elute from the cells. So eluates are also non-reactive. So this IgG autoantibody is a biphasic hemolysin and has anti-P specificity, which is also called Donat-Landsteiner antibody. This one is very important. You remember sometimes in ASCPi you will find this term, Donat-Landsteiner. So Donat-Landsteiner antibody, it is anti-P antibodies. So anti-P, they are found in PI group system, right? P1, PPK, P1 and P2 and so on. So we have anti-P. Anti-P is what we call Donat-Landsteiner, and it is associated with the paroxysmal cold hemoglobinuria, right? Paroxysmal cold hemoglobinuria. You remember, but we will see it maybe after tomorrow. We will see this other blood group system. You will find that anti-P is associated with paroxysmal cold hemoglobinuria, and it is what we call Donat-Landsteiner antibody. So in this condition, you can see now that even if this antibody is biphasic hemolysin, but it cannot also be able to be detected. It is not detected in eluates. It is now able to destroy RBC at a warmer temperature of the body, but it elutes from RBC immediately. So when you collect a blood sample, you can't find them on red blood cells. You can only be able to find only complements there. So that's why we say eluate is non-reactive. So drug-induced hemolysis is the last one, of course, in autoimmune hemolytic diseases. Drug-induced hemolysis is, of course, the last one. So drug-induced has been associated with different mechanisms, for example. So drug-induced is associated with drug adsorption, immune complexing, membrane modification, and autoantibody formation. So this is what you call drug-induced hemolysis. It is also another type of autoimmune hemolytic disease as well, because this is because of the immunity. So the first thing is what you call drug adsorption. A classic example of drug adsorption is penicillin, and in this mechanism, drug is now able to bind strongly to any protein of the RBC. For example, RBC membrane protein. So drug is able to bind on these membrane proteins of red blood cells, and the binding can stimulate antibody formation, which is specific for this complex. For example, this is autoimmunity. But it is drug induced, because drug now, like for example penicillin, binds on RBC proteins membrane proteins, and binding of these penicillin to RBC membrane proteins will stimulate autoantibody formation, which then come and destroy RBCs. So that is how drug adsorption mechanism works to generate RBC autoantibodies that are going to cause hemolysis. The second mechanism is called drug immune complexing. Immune complexing happens with different kind of drugs. You have to be so cautious with these terms, because you remember sometimes ASCP questions in immunology. Immunology is not too wide. They will still get questions from anywhere. For example, you could actually be asked which drugs that are associated with immune complexing in autoimmune disorders. So of course, autoimmune hemolytic disease, which drugs are associated with immune complexing. Those drugs are phenacetin, quinine, rifampin, as well as stibofen, are all associated with immune complexing. So what happens in this mechanism? There will be the interaction. There will be interaction with antibody and drug to form a complex. A drug and the antibody will form a complex, and in the serum, then they attach non-specifically to the RBC, which initiate the complement cascade and always culminates in intravascular hemolysis. So what will happen when you take, for example, quinine or rifampin? So these are just good antimicrobial agents, antimicrobial drugs, or antibiotics. But when you take it, like for example, rifampin, it is going to complex with specific antibodies to this rifampin. This is antibody produced because of rifampin in blood. So this antibody is going to complex with the rifampin. Then the complex is going to attach non-specifically to any RBC around in the blood, and this attachment of that complex to the RBCs is going to initiate complement cascade. Of course, complement cascade is going to end up destroying red blood cell because of membrane attack complex that is going to form at the end of this complement cascade activation. So that's what you call intravascular hemolysis. So also, the third mechanism of drug affecting or causing hemolysis, it is what you call membrane modification. So membrane modification goes with some drugs, for example, cephalosporin type drugs like cephalotin, which alter membrane so that there is non-specific absorption of globulins, including IgG, IgM, and IgA, and eventually activate complements. This is also another problem of drugs. For example, cephalosporin. Cephalosporin is also a drug, is a therapeutic drug. When it is taken, it will destroy, or it will alter, or it will disturb membrane of red blood cell, which is going to recruit attachment of some antibodies on red blood cell because of membrane modification and eventually activation of complements. This will also lead to destruction of cells because of complement activation. So the last one is autoantibody formation. So some drugs that can lead to autoantibody formation include methyldopamine, levodopa, and also mefenamic acid. All these drugs are implicated in autoantibody formation. So if you are taking them, if you are taking, for example, methyldopamine, is going to cause formation of autoantibodies which will recognize a part of RBC, especially rhesus antigen. If someone is having rhesus antigen, will be targeted by autoantibody produced because of these drugs. So this actually is going to cause destruction of RBC. So this will stop when you withdraw from drug. For example, of course, when you stop taking methyldopamine or levodopa, these antibodies are going to cease. So those are the four mechanisms by which drugs can induce autoimmune hemolysis. So the another autoimmune disease, it is idiopathic thrombocytopenic papilla. You know this one, idiopathic thrombocytopenic papilla. It goes with the platelets and bleeding, right? You remember this one. We may not maybe describe it a lot because we have seen it in different presentations, but of course, simply, this is what you call TTP, or thrombotic thrombocytopenic papilla. It is also called idiopathic thrombocytopenic papilla. It is characterized by petechial bruising, menorrhagia, and bleeding after minor trauma, and this is because of destruction of platelets. So due to, and of course, destruction of platelets is going to lead to thrombocytopenia. Thrombocytopenia with decreased platelets. So platelets can be affected, or they will decrease because of different mechanisms. For example, decreased production of platelets, decreased platelet distribution, and also increase of destruction of platelets. So for example, decrease of platelet production will result from any problem of the bone marrow. For example, invasion of the bone marrow by neoplastic cells. So neoplastic cells are those malignant cells that will invade the bone marrow, and they cause decreased platelet production. So, and also platelet distribution is associated with sequestration of platelets in the spleen because of some reasons. But increase destruction of platelets, it is what is forecast here. It is associated with the immunologic mechanism. For example, antigen and antibody, and you know what you call human platelet antibody, human platelet antigen 03 or A or 01A. So those are the antigen specific on antibodies that are normally targeted by immune system. So drug can cause platelet destruction, and those drugs that can lead to platelet destruction include quinidine, sulfonamide derivatives, heroin, morphine, snake venom, and so on. So these drugs, or these chemicals, or these substances can lead to, if one take these substances or drugs, they lead to platelet destruction and of course thrombocytopenia. So sulfonamide derivative can cause platelet autoantibodies, and morphine, of course, will activate complements, and many other bacterial sepsis, for example. Bacterial sepsis can also cause destruction of platelets because of attachment of platelet to the bacterial antigen, and then cause antibody immune complex, which leads to destruction of platelets. So that normally occurs more specifically in Plasmodium falciparum malaria. You know, in Plasmodium malaria, you know, if you are experienced in malaria diagnosis, you remember that Plasmodium falciparum, especially in severe malaria or severe Plasmodium falciparum malaria, there is a tendency of also showing thrombocytopenia or low platelet counts. That is because of increased destruction of platelets because of attachment of platelets to bacterial antigen or to parasite antigen, and then this can complex it with antibodies, which normally come and destroy all of them together, destroy platelets and also destroy also the bacteria or parasites causing this. So there are many other antibodies that can also lead to thrombocytopenia, including, of course, post-transfusion papilla. Those are other isoimmune antibodies against platelets. So other mid-spectrum autoimmune disease include also neuromuscular disease. Of course, the immune system may play very important role in the pathogenesis of many neuromuscular. Neuromuscular disease are those disorders associated with the central nervous system and muscular system. And those diseases are, for example, myasthenia gravis, multiple sclerosis, as well as amyotrophic lateral sclerosis. So those are neuromuscular disease, of course, which also are affected or are caused by autoimmune, or they involve autoimmunity. So the first is amyotrophic lateral sclerosis. this is also another condition which affects the central nervous system, along with Alzheimer's disease and Parkinson's disease. You know, we have Alzheimer's disease is also a disorder of the central nervous system, and Parkinson's disease as well. So amyotrophic lateral sclerosis is one of the so-called degenerative disease of the aging nervous system. Degenerative diseases of the aging nervous system, which of course include Alzheimer's disease and Parkinson's disease. So monoclonal paraprotein seems to be excessively frequently in patients with amyotrophic lateral sclerosis and higher incidence of lymphoma and one-stroke macroglobulinemia and myeloma. And there is also increased frequency of antibodies to neuronal gangliosides or GM1. So these are some of the antibodies or immunologic factors that are present in these conditions, amyotrophic lateral sclerosis and other neurodegenerative diseases, of course, of aging or elderly people, because they are mostly affected. But also, there is also incidence of transforming these neurodegenerative conditions to other problems, other serious disorders, for example, lymphoma and myeloma as well. So because also multiple myeloma is also a plasma cell dyscrasis or a plasma cell disease. The second neurodegenerative disorder is called inflammatory polyneuropathies. Inflammatory polyneuropathies has been associated with the Guillain-Barré syndrome. You know what you call Guillain-Barré syndrome, which is characterized by subacute onset of general systemic weakness, ranging from modest lower extremity weakness to total life-threatening involvement of the motor and even cranial nerves. This is what you call Guillain-Barré syndrome, and sensory symptoms are sometimes less prominent, but motor symptoms and the cranial nerve symptoms are very common. So unstable blood pressure and potentially fatal arrhythmia has also been observed in Guillain-Barré syndrome. So Guillain-Barré syndrome, it is a type of inflammatory polyneuropathies. So the cause of Guillain-Barré syndrome is actually unknown, but it is likely sometimes associated with the other infections, for example, antecedent viral infection. But this abnormal immune response against peripheral nervous system, it can also trigger Guillain-Barré syndrome. So there is also infiltration of the peripheral nervous system with the lymphocytes, macrophage, and also other destruction of, for example, myelin destruction. So the position of some antibodies, for example, antibodies in form of IgG, IgM, and IgA in the peripheral nervous system tissue, it is a sign in Guillain-Barré syndrome. But of course, the target of those antibodies are not known, but those antibodies are normally seen in Guillain-Barré syndrome. The myasthenia gravis is also another central nervous system degenerative disorder. Myasthenia gravis, it is also an autoimmune disorder. Myasthenia gravis is a disease of neuromuscular junction, which is characterized by neurophysiologic and immunologic abnormalities, of course. So, and this is normally a problem in myasthenia gravis is a post-synaptic defect. So a post-synaptic defect is caused by decrease in receptors for acetylcholine and frequently anatomic defect in neuromuscular junction plates. So this is what's happening in myasthenia gravis, is the abnormality in neuromuscular junction. So then it is going to block acetylcholine. So acetylcholine receptors will be blocked by autoantibodies that are targeting or directed against acetylcholine receptors at the neuromuscular junction. Because acetylcholine is a neurotransmitter that should pass through synaptic area or synaptic zone between the neurons. So because of these defects, acetylcholine receptors are targeted by autoantibodies, and of course that will impede neurotransmission, and this is what we call myasthenia gravis. So apart from myasthenia gravis, also we have also multiple sclerosis. You know, multiple sclerosis is very common disease, and multiple sclerosis, it is also demyelinating disease of the central nervous system. And of course, etiology of multiple sclerosis is not known as well, but viral infection has been associated with multiple sclerosis, and sometimes apart from human herpes virus 6, it is also sometimes suggested that Epstein-Barr virus is also associated with this, which is normally, first of all, associated with infectious mononucleosis, but these infectious mononucleosis can also lead to multiple sclerosis. So pathophysiology of multiple sclerosis, it is associated with T lymphocyte dependent inflammatory demyelinating of the central nervous system, and inflammatory demyelinating caused by T lymphocyte induce B lymphocyte to produce anti-myelin antibodies. So anti-myelin antibodies are produced by B lymphocytes because of the induction or the election of T lymphocytes to the B lymphocytes. So the symptoms in multiple sclerosis, of course, include relapsing illness with neurologic dysfunction episodes, which last for many weeks, which is followed by substantial or complete improvement, which is called remission time. But of course, that is a relapsing illness. It will also reoccur again after improvement. So that is how multiple sclerosis affect patients. So initial symptoms of multiple sclerosis is difficulty in walking, abnormal sensation, for example, numbness or possible pains, or ineffective vision. So primary symptoms is caused by demyelination, which include fatigue, bladder and bowel dysfunction, loss of balance, loss of memory, slurred speech, and many other like difficulty swallowing and seizures. But depression is very common symptom in multiple sclerosis, and the relapse of this multiple sclerosis is very common, and 80% of patients are symptomatic at the onset of this disease. So at the beginning of this disease, of course, symptoms are there. Patients experience symptoms. Other forms of multiple sclerosis, the form of multiple sclerosis can be primary progressive form, secondary progressive form, and progressive relapsing. So where the primary progressive, it is an insidious form of disease without plateaus and without improvement. For example, this primary progressive multiple sclerosis is a progressive disease without any plateau. Plateau means peak and also improvement. So it is just a straightforward disease which will not have any improvement or any relapse. Whereas secondary progressive, it means it is a relapse of disease that has been there for many years. Then there will be a secondary relapse later. That's what we call secondary progressive. But progressive relapsing is what is happening, occurring, and the relapse and improvement and the relapse, which is a repetitive process. So that's what you call progressive relapse multiple sclerosis. And diagnosis of multiple sclerosis, of course, it is by magnetic resonance imaging, but also sometimes no lab test is there for multiple sclerosis. But as you remember, you can collect CSF and you analyze the CSF. And CSF, you're of course expecting to see IgG antibodies on electrophoresis. You remember we did it in body fluid analysis. You can be able to detect IgG on IgG peak on the IgG site on the electrophoresis of the proteins. So that can be suggestive of multiple sclerosis. But apart from that, immunological manifestation of multiple sclerosis, it is autoantibodies against myelin sheet of the neurons. We call them anti-myelin antibodies, which are detected against a myelin sheet of the nerves or myelin disc proteins. So, but also sometimes you should also expect some other IgG antibodies that will be seen on electrophoresis on the band of the IgG. So that is done on serum electrophoresis. So finally, we have also renal diseases. For example, we have renal disease associated with the circulating immune complex. So those immune complex are deposited on glomerulus, which will induce, of course, destruction of the glomerulus and cause glomerulonephritis. Another type of renal disease autoantibodies or autoimmune diseases include renal disease associated with anti-glomerular basement membrane antibody. This is what you call anti-GBM. This is antibodies that is against the glomerulus basement membrane, and also renal tubule or lungs. So those can be seen, sometimes they can be also stimulated by some drugs, for example, methicillin drug, and sometimes infections. So those infectious agents or infections and drugs, for example, methicillin, can stimulate antibody production against glomerulus basement membrane, and this can lead to glomerulus basement membrane autoimmune disease. So in this condition, we are able to find anti-GBM, so which is anti-basement membrane, which is a suggestive of good prostate disease, which is of course a kidney disease or a glomerulus autoimmune disease, good prostate disease. And also anti-basement membrane, anti-glomerulus basement membrane antibodies can also be found sometimes in anti-GBM nephritis and systemic lupus erythematosus. So, but their absence does not rule out Goodpasture syndrome. Sometimes even Goodpasture syndrome can occur without anti-basement membrane antibodies. In fact, sometimes other antibodies can be associated with Goodpasture syndrome. So finally, also skeletal muscle disease, for example, inflammatory myopathies. We have seen different categories of inflammatory myopathies, including primary idiopathic polymyositis, primary idiopathic dermatomyositis, and also other associated with the neoplasma, and also childhood problems of this condition, and also these conditions associated with the collagen vascular disease, that is dermatomyositis and the polymyositis associated with the collagen disease, and also others that are associated with infections. So the conditions affect skeletal muscles and they cause damage of skeletal muscles. So for example, polymyositis may be accompanied with inflammation of other sites, especially in the joint, lungs, and the heart. But dermatomyositis is different. It is only associated with skin inflammation, but without involvement of other organs like joints, lungs, and heart. So that's the difference between polymyositis and dermatomyositis. So polymyositis is it also involves other organs like lungs and heart, whereas dermatomyositis is inflammation of the skin only. So in fact, of course, you could find different clinical manifestations, including pain, fatigue, and low-grade fever, and also, but both of these diseases are associated with immune destruction. Those are the antibodies that are destroying different organs, including skin and also collagen tissues. What you will find here, you find at least IgG antibodies and complement deposition in vessel wall and also in skin, as well as, of course, the availability and preponderance of B lymphocytes and also CD4 increase in those areas, skin, and also some other tissues that are affected by polymyositis. So patients with the myositis have targeting autoantibodies against cytoplasmic protein and ribonucleic acid, which are also known as myositis-specific autoantibodies. So in polymyositis and dermatomyositis, in vascular disease syndrome or vascular autoimmune diseases, we are able to detect these autoantibodies, anti-cytoplasmic protein autoantibodies and anti-ribonucleic acid autoantibodies. So why am I focusing on autoantibodies? It is because for you to know that you understand autoimmune diseases, you must be able to describe, or you must be able to understand which antibodies are involved in a certain autoimmune disease. So thank you so much for your time. This is the end of today's discussion. I hope to see you tomorrow when we'll be discussing systemic autoimmune disease as well as systemic lupus, erythematosus, and other systemic disease like rheumatoid arthritis. Thank you so much. God bless you.